Good afternoon. First of all, I'd like to thank Manos for inviting me to this really great meeting. It's always a pleasure to be here in Greece. I've been many years, John in the past, and Manos invited me. It's a great time to be here. Just to let you know where I'm coming from the big city called Reading. We are just west of the small village called London. So infection affecting total shoulder arthroplasty or shoulder arthroplasty and the surgeon perspective. These are my disclosures, nothing to disclose regarding this talk. So infection rate, as we heard, is about 1% in general. It's slightly higher in revision surgery, and it's higher in reverse arthroplasty. And it's probably even higher, probably much higher, because of this low-grade infection with a P. acnes that we are now seeing more and more, or more aware of it. So in microbiology, again, as we heard earlier from the previous speaker, the Staph aureus, Staph epidermidis give us the classic signs of infection, but the P. acnes, which actually is 50 to 70% of the common pathogen in joint replacement infection, is a low-grade infection. There's no clinical signs of infection. The serum ESR and CRP are normal. It's difficult to grow in culture, and it needs long time to keep in culture, two to 3 weeks. And the histology, there's no 5 polymorphonuclears per high power field. So actually, we don't see that. We see lymphocytosis rather than that. So that's actually brought us, when we did this study that actually created a lot of noise around, we found actually in this study 42% of primary total shoulder arthroplasty, they had P. acnes in the joint, in the synovial fluid. And the question whether we underestimate it in the etiology of osteoarthritis, or it is a cause of late postoperative pain, loosening, and infections. And as I said, we actually found in almost 42% of patients undergoing primary total shoulder arthroplasty with osteoarthritis and cuff arthropathy, positive for P. acnes. We did it in a very meticulous way. We collected the specimens. We had 7 specimens for each patient. We replaced the scalpels and the instruments before we got into the joint. So it was really, really done meticulously, and a very meticulous technique in the lab. And if we look actually on other studies, we know that we see that this group from Mayo Clinic, Topolsky and his colleagues, they found about 60% positive P. acnes in so-called aseptic shoulder loosening. And again, if you go, Levy, this paper, again found about 56.3% of the patients with aseptic loosening were actually P. acnes. If you looked properly, the same as Pottinger, it was mentioned earlier, about 56%. So we know it's there, and it's in high proportion. And the question is, again, whether, an unrecognized low-grade infection at the time of primary shoulder replacement may be responsible for all these patients that come to us. They don't seem infected, but they're painful, they're stiff, they're not good, they're really not good. And they come with some aseptic loosening, like you can see here. So when you see this picture, when you see this patient, stiff, pain, some loosening, always think P. acnes. So as we heard before, we have 2 types or several types of infection. We have acute early postoperative infection, or we have an acute late, which is hematogenous usually, infection. But these are acute infection like we expect to see. And we have the low-grade infection. Again, we have to differentiate between early and late, and actually, I wrote here 6 weeks, but actually I agree that it should be less than that. As quicker as we act, the better. So clinical suspicion, again, if you have chronic pain, stiffness, early loosening, osteolysis, high index of suspicion for infection with P. acnes. If you have a macroscopic sign of infection, that's clear, that's easy. You have the obvious signs of infection, of redness, swelling, draining sinus, pus, etc. That's clear, that's easy. Macrobiological diagnosis, as we heard before, is not great. CRP is negative in 75% of the cases. ESR is negative in 86% of the cases. Synovial interleukin-6, maybe, but it's not great. Alpha defensin, again, maybe, but again, for P. acnes, it's not great. Aspiration, about 50% of the cases will not give you a positive result. Sonification PCR, maybe there's some promise with that. We are doing some studies with PCR now. We hope that this will give us better outcome, but again, it's only at the beginning. And always think about extended cultures, always think about P. acnes, and as the previous speaker said, take at least 5 specimens and send fluid and tissue to the microbiologist. Oops, what happened? Something happened here? We lost this. Sorry. So we said alpha defensin, again, maybe has some promise, but again, it's not great with P. acnes, it doesn't really work. So what are the treatment options that we have? We can do an arthroscopic debridement and washout. We can do a debridement washout and exchange of the modular parts, and that's mainly in acute early infection. We can do a single-stage revision, we can do a 2-stage revision, permanent spacer with ongoing antibiotics, resection arthroplasty, arthrodesis, or just an antibiotic suppression without doing any operation, again, in extreme cases, very sick patients. So debridement, if you have an acute early infection, ideally less than 3 weeks, the earlier, the better results are. And the best, it's for implants with less or no modular parts. So for instance, for resurfacing, or something that minimal modular parts, so that there's no sanctuaries for the bugs to hide behind. And you may repeat it if necessary. You have to give an antibiotic regime, which is effective, pathogen-directed, specific, and usually dual antibiotics, as the previous speaker mentioned. You must give rifampicin as well, because the rifampicin actually break the biofilm. And here you can see, this is actually x-rays of a patient. She's 17 years after a washout for acute infection. She's doing well, no problem. We managed to save the implant for 17 years. Yes, she's got erosion and all that, but the implant is safe and she used the implant for 17 years. Debridement and washout and exchange, again in acute early, again less than 3 weeks. Again earlier, the better the results. Exchange of the modular parts, you may repeat it as well. And now what I use in recent years, I use these beads of implantable antibiotic-loaded biodegradable beads with antibiotic, usually dual antibiotics. And these are, I put it in the bone, around the implant, in all the layers. And actually, this dissolves within a few weeks, but discharge the antibiotics, and it works very well. So you can see this gentleman here that had a debridement, washout, and exchange of the liner and the glenoid head. And actually, you can see he recovered. This is now 2 years after the event. He's fine, no signs of infection. And again, as you can see in the papers, the 70% you can retain the implants with good outcome. And again, as I said, the more aggressive you are, the earlier the surgery, the better the results. Single-stage revision, and this is important. You have to stop antibiotic treatment at least for 2 weeks before the operation, because you want to take specimens to know what the bug is. Now, you have to take multiple micro specimens from everywhere around the implant. You have to withhold antibiotics, not to give antibiotics prophylactic until you take the specimens, and they have to remove all the implant, including if there's cement or whatever, everything should go out. You should do a meticulous debridement and washout, like I call it a tumor surgery. You have to get rid of everything that's there, and then you can reinsert the new prosthesis. Again, it's better if you know the bug beforehand, it's easier, but even if you don't know the bug, you can still do it, and again, using these stimulant beads, these resorbable beads, and give an antibiotic regime, as we mentioned. So, for example, this gentleman is a 55-year-old guy, had a total shoulder replacement, and did very well, but then a few years later, he developed infection in his toe, and the infection got to his shoulder, developed this sinus, and then it was referred to me with this infected shoulder. We knew that he's got Staph aureus, so actually what we did, we removed the implant. I was really lucky because it was infected, so I could remove this prosthesis easily, because usually it's a nightmare to remove a prosthesis like this. What we did, we actually, as you can see here, we put the beads inside the bone, inside the glenoid as well, around the tissues, in all the layers, and this is how the X-rays immediately post-operative was recorded. And this guy is a year down the line, healed nicely. There's no signs of inflammation, no signs of infection. He's got relatively a good function. He's happy with it. You see that everything has dissolved. Some of the bone graft in the bone has actually became a bone around the implant. So you can do that. This is another patient that actually came from Canada with this painful stiff resurfacing. The question whether he's got a low-grade infection, everything was negative. Nothing was there. But I felt like, for me, it was infected until proven otherwise. So I did a revision, because you see he's got severe erosion and he had no cuff, revision to reverse shoulder replacement to the verso with these beads. And this is actually him a year down the line. And actually this is me doing a Skype follow-up a few weeks ago from Canada. And you can see he's got excellent function. He's got no signs of inflammation or infection with this treatment. So a single-stage removal, you have to, as I said, stop the antibiotics for 2 weeks. It's got good clinical outcome. In the past, people thought that this is inferior to the two-stage in the past, but I think that it's now clear that this is a good solution. Good eradication rates, more than 90%, less surgery, better if the organism is known, and fistula is not a contraindication to do it. But there are not a lot of studies published about it, and it can be a problem if you have to use a massive allograft where you can't really protect it from being infected again. So you can see here that overall the results of the eradication are pretty good in these different studies. Two-stage revision, again, the first stage is the same as we did for the single stage, but we remove everything. We insert an antibiotic-loaded spacer. We use, again, these beads of stimulant, or use beads of cement. Some people, that's the old technique. And antibiotic regime, then come back. This for second stage, about 6 to 12 weeks later. We have to make sure that all the parameters are down, all the markers are down. We repeat the old stages, again, take specimens, again, clear everything, and then put the new prosthesis, again, with these beads that we use now, and antibiotic regime. So when the organism is not known, you may go towards the two-stage. The spacer is, with antibiotics, again, as I said, 6 to 12 weeks. And again, you stopped antibiotics 2 weeks before the second operation, again, and the results are pretty good. This lady actually was a revision of, a second revision of operation. She had a one-stage exchange that didn't work, and then she came for this two-stage revision. You can see that we created a spacer and using that. And then this is the second stage, and this is her two years later after the revision. Again, we had to put a stem here because the proximal bone was a bit missing. And you can see that the results overall are good, but not as good as for the single stage. So I think that now the wind is changing toward doing a single stage more than two-stage. This is a study that looked at different papers, and you can see that they had a 26% recurrence rate in two-stage procedure, and the P. acnes behaved badly or worse. And this is another study. This is that looked at a literature review, and actually there was no difference in infection eradication. The single stage, however, had significantly better functional outcome and better constant scores. It's obviously less surgery, and the recovery is quicker. So we have to bear that in mind. If the next stage is to put a spacer, and sometimes we do first stage, and the patient says, leave me alone, I don't want to do anything else, and we manage to eradicate the infection, so these spacers may work. Again, it's for medically unwell patients. You can see another thing is resection arthroplasty, and this poor gentleman, actually it was a salvage procedure for him. He had a sinus pouring past, nobody wanted to touch him, and eventually after 5 operations we managed to get rid of the infection, and this is the result. So it doesn't have good function, but at least he's pain-free. And another thing is arthrodesis we have to bear in mind. So to conclude, we have to tailor the treatment to the patient. We have to have high index of suspicion. We have to be aggressive with acute infection, act fast. And we have to stop antibiotics for 2 weeks before surgery and withhold antibiotics until we take the specimens. We should take multiple specimens and actually take them, as the previous speaker said, by the hand to the microbiologist. Very quickly, it should go to the microbiologist, not sit for 2 days on the table. Have a meticulous debridement and washout. It's better if we know the causative bacteria, but always suspect P. acnes and consider the use of these beads, resorbable beads. And the best is prevention. I would like to take this opportunity to invite you all to this special event that we want to do in Israel later in November. It's called the Shoulder Safari, International Shoulder Safari, that will be a traveling safari through the country with high-level discussions. So you're all welcome. All the information is on the website, shouldersafari.com. Thank you very much.